Hello, everyone. How are you? I'm Robert Riley. I'm going to be putting a full arch implant rehabilitation, starting with the why. I'm going to start off with the disclaimer that I want to thank Biotech Dental Implants for supporting today's lecture, and can't thank enough Ms. Randy Miller and Stephen Pfeffer from Biotech for introducing me to this wonderful system. Who am I? Well, I want to thank you for tuning in and tell you it is to speak to you. I know your time is valuable, and I hope I make your time invested tonight worthwhile. Trust me, I get it. You may have many options for CE, and I know many of you are balancing lots of other pending matters. So I just want to thank you and say that I'm humbled. I am fortunate to be in a position where I get to teach and be involved in surgical training of dental students, be an attending surgeon for the head and neck reconstructive oral surgery fellowship at Mercy Hospital in St. Louis, as well as be involved in the training of ENT and plastic surgery residents at Washington School of Medicine here in St. Louis as well. And why I feel blessed because these students keep me grounded in the world of production, business stresses, and lifestyle choices. These doctors in training continually remind me of my training, the purity and passion of treating patients. They remind me why I started down this journey, the satisfaction of performing surgeries, and the wonderment of seeing the results without the clouding of all the other distractors. I'm truly blessed to have made so many amazing connections in this world. I could not have done it without these amazing people who keep my flame of passion lit and focus on the why I have devoted my time to this amazing field. So why listen to me? You shouldn't listen to me. You should come learn with me. I'm still learning and growing, and I love to teach. By writing this lecture alone, I get to review my work and critique it. I'm just sharing my experiences. It's on Instagram. I'll show you my cases, the ugly and the picturesque. By sharing my experiences, we can learn from one another, as also hopefully avoid some oopsie moments. So start with why. I'm going to make a dangerous assumption that during many of your dental school interviews, you're asked why. Why do you want to be a dentist? I'm going to assume lots of us discussed how a dentist either changed your life or you wanted to make this a better world. There's a time in our lives when our intents were truly pure, no external factors. Kind of like kind of like my students in training. It was truly patient centric in a world of social media and training videos of everything made to look easy. I've seen the fear of missing out. In my opinion, lots of people are jumping on the all on X trend. It seems everyone is doing it, but there's a huge investment of capital and time and a long learning curve. And if you don't come to terms of why you would like to include this in your practice, it can be a miserable experience. There's a great book by Simon Sinek on how great leaders think, act, and communicate. It's not only important for you to be passionate about all on X and solidify your why, but your passion needs to be infectious. This is not a single person adventure. This is a team sport. After you find your why, you need to convince your team they are changing the world with you. It is this cohesiveness that will make you successful, and the patients will be able to tell. I can tell you if you're starting to, I can tell you if you start doing this, the lows are low, but the highs are incredible. There'll be lots of extra hours with your staff. You need to know why you're doing this. As once you treat a patient, they're truly your lifetime patients. Your oopsies will follow you. If you understand what you are providing and not selling, this all starts to make sense, not only to you but your staff, as they need to be on board, and the patients will see this. If you can find your why and light the flame of why in your team, the journey will be fruitful. It'll become obvious when you explain the treatment to your patients. You're not trying to sell them teeth, but health, physical and mental health, a better quality of life, allow them to live longer and happier lives. Then the how you get there through investment in equipment and education, it will be worthwhile. You will get to the what, being satisfied and having healthier patients. In my mind, this lecture will be successful if you can give you a sense of what my why is. Dr. Fredemark, founder of Implant Dentistry, made his why to give people their dental health back. In 1953, he figured out to titanium fix the bone. In 65, he did really his first quasi all-on-4. His passion to restore dental health led to a multi-billion-dollar industry and changed countless lives. He wanted to give people their teeth back, and that is the essence of what we should be appreciating. Still makes me cringe when I see 20-year-olds waiting to get their dentures because their family has soft teeth. The idea of making a human being an oral debilitate upsets me. But we have made the public feel that teeth are a luxury. If they only knew how important how teeth are to our overall health. Your teeth play a big role in your digestion and your health. Having teeth is a sign of general youth and health. They cut and crush foods, making them easier to swallow. It allows actual healthy, meaningful nourishment to enter your body. We need to establish the mindset in the populace: teeth are not a luxury, but a part of our body. The CDC Center for Disease Control states that cavities are one of the greatest unmet health treatment needs. So we have to understand this is a disease. A disease is defined as a disorder of structure or function in human, animal, or plant, especially one that produces specific signs or symptoms or that affects a specific location and is not a direct result of injury. Edentulosum does have signs and symptoms: enlarged tongues, overclosure, TMD issues, pronunciation issues, aesthetic issues, masticatory issues. This is truly a disease and has specific sequelae that affects the entire body. We are not. We have to change the mindset of what we are of who we are and what we are doing. How many times have you heard a patient trying to haggle fees with you? Would that fly in a medical practice? You're not tooth carpenters, but doctors of the oral cavity. You're treating not teeth, but curing a person from disease. We need to retrain our staff and ourselves that we're not selling teeth, but health. 90% of those who have edentulum are indentures. This is not my favorite option, okay? Teeth, historically said, have been seen as a nuanced, non-actual organ in our body. Too many times we are hearing, that I'm too old for putting money into my oral cavity or my teeth. My parents all lost their teeth young. Doctors pull them out. Whatever my insurance covered, just do it. I got the soft teeth. If your foot was green, would you say just cut it off? If we extrapolate from this study of the US, about 15% of the population over the age of 65 suffers from edentulosum. That's about 50 million people in the US. That also means about 50% of your practices, of your patients of record, are suffering from this disease. What are you doing with them? And do they know they have a curable disease? Keep in mind that my time's limited. I encourage you to read all these articles on your own. Most articles I'm going to present with just the highlights, just kind of get my points across. Although in this article, the powers are small, it really does bring home a point. They study patients with teeth in the upper box and those in brand new dentures in the lower box. What do they find? Mastication in complete dentures was 7 times less effective when it came to chewing. Patients required smaller bites of food, smaller portions. As you all know, people who are dieting tended to have smaller bites to try and increase their satiety. The masticatory load in natural teeth about 200 newtons maximum force, while those who are in complete dentures, their maximum force was between 60 and 80 newtons, but 1/4 of those with teeth. We must keep in mind that this study excluded other health factors like xerostomia. These were ideal conditions of new denture wearers. How many patients in your practice are on multiple medications? Number one, consequence being xerostomia. And these patients will keep on aging. Their dentures are going to become less fitting, okay? And the problem is, as we know, as people age, getting in food to them is harder. Their desire to eat just decreases. Now you're adding on this extra stress of chewing more and therefore taking longer to actually break down these foods, and therefore their satiety comes in quicker. In this study, a total of 12 edentulous patients were made conventional dentures. They were then divided into 2 groups. In group 1, they had complete dentures, which were replaced with an implant-supported overdenture. In group 2, they were basically given all-on force. The biting force was assessed using a bite force sensor, and you can just see from the placement of an overdenture how it dramatically increased their biting force. And keeping in mind that the previous study showed that the natural biting force in a dentate patient is usually 200 newtons. The all-on-4 basically gave them back their oral health, the ability to chew with normal strength. Here's something that's going to shock you. Foods higher in fiber and nutrients tend to be more difficult to chew. The impact of edentulosum on your general health is widespread. lower intake of fruits and vegetables, fiber and keratin will increase with the increase in more softer, more processed foods, which have higher cholesterol and saturated fats, which then can lead to higher, rates of obesity, cardiovascular disease, and gastro and GI issues. Also, you see increased rates of chronic inflammatory changes of the gastric mucosa, leading to higher risk for upper GI and pancreatic cancers, higher rates of peptic and duodenal ulcers, higher rates of diabetes, increase in cardiovascular disease such as hypertension, heart failure, and ischemic heart disease and stroke, and aortic valve sclerosis, increase in chronic kidney disease. There's association between edentalism and sleep disorder breathing, also known as OSA. The life expectancy of those without teeth decreases, and they have found that each tooth that remains in the oral cavity after the age of 70 decreased the risk of mortality over 7 years by 4%. Several studies have established an association between edentalism before the age of 65 with the increase in earlier death. So we can see having teeth has a wide range of effects on your body, not only on your physical health, but also on your mental health as well. Not only are you improving their physical health, but their mental health. How many times have you seen a patient tell you they have not smiled in years? That is not normal. That is crippling anxiety. We have the skill set to treat these patients. Another paper showing how edentalism is associated with low self-perception and higher risk to suffer from depression, which is another disease. But why? What is my biggest why? Just look at this patient. This patient looks healthier, happier, and younger. Look at the nasolabial folds, just the strength of the muscles. It's not the same person. This person will live a longer, healthier life, mentally and physically. They'll experience life differently. They'll interact with the world differently. Once you know your why, the how is worth going through. And how is the process, how we actually get there. So I'm not going to beat a dead horse, but let's be honest, online is not a new thing. It's probably it's probably the most copied dental procedure on the planet. It's well studied. All the concerns have been ironed out. It is a proven, repeatable, predictable treatment. It is an efficient method to give people back their oral health with low risk, reduced pain, the time of grafting, and overnight, we can give them back a smile and their ability to chew. Why would you not offer this to a patient? They're suffering from a disease, and we can fix that and make them better. It isn't what isn't this what you told on your dental interview, on your entrance exam. It's exactly what you wanted to do. So how does this all work? The best way to understand the mechanics is referred to a beam system. There's a load being your bite that's applied to a structural member that causes loads, shear forces, and bending moments. The traditional all-in-4 works more like an overhanging beam, labeled in number 3. Ideally, we would like to have each segment of the prosthetic supported like a continuous beam. Hence, you see terms like all in X being the placeholder for the number of implants that you're going to place. This makes the most sense mechanically, but either work and both have been proven in countless studies. We hope to give our patients a full complement of teeth up to the first molar. We also want all the ends of the framework to be supported if possible. It's not always possible due to the anatomical limitations like the maxillary sinus, the mental nerve, or severe resorption. This leads to free ends, which we call cantilevers. The longer the cantilever, the load applied to it, it makes a much larger force, which is in mechanics called the fulcrum. The length of the cantilever multiplied by the occlusal force is called the bending moment, force times length. So a larger cantilever inherently leads to much greater bending moments. This can lead to failure. If the weakest link is the framework, the cantilever arm will break off. If the weakest link is in the posterior implant, the implant may experience bone loss or failure. If the weakest link is in the anterior implant, the implant may experience bone loss or failure. If the weakest link is the prosthetic screw, it may loosen or break. Obviously, the shorter the cantilever, the less bending moment, and more likely the prosthetic and its components can resist the force of chewing. So the question is, how do you restore the head of a tilted implant? Well, you place a multi-unit with varying degrees to bring the prosthetic platform back into appropriate position. But you can see just how much more gain in AP spread you would have on a tilted implant than a more axial placed implant. And we'll get more of that in a few moments. Now the how. Well, the how is going to take time and money. Implant dentistry is an investment. CBCTs are the standard. CBCTs will give you a lot of good information, like do you have enough bone? Can you get enough AP spread? Do you need to do dental extra alveolar implants in order to achieve the AP spread? I'm not going to go off on those on this lecture. Obviously, planning is important. You measure 3 times and you cut once. You take photos. I would kind of argue that you need to have some sort of guide, even be an XNAV or a stackable guide, or if you're really confident, you can just kind of plan on the cone beam and place the implants freehand. I personally like guides, but the key is you need to be able to kind of do all this and hide the transition line, being the prosthetic and the gums that remain. So the standard is about a 15 millimeters of room for reduction to kind of take in all the thickness of all the components, but it's not always true. I'll show you a case. Hence, you need to plan. If you plan on loading the same day or soon, you need to have some kind of design of the implant as well as your implant placement to try and gain some primary stability of those implants. Typically, you need about 30 Newton centimeter or greater per implant to load. The question is, do you actually need to load the same day or not? They live a good part of their lives without these teeth. Can they go on and heal traditionally? Those are all questions which you have to ask, yourself. Now, I'm not going to bore you, but again, measure 3 times, cut once. It all starts with the basics. Photos will not only help you handle the expectations of the patient and act as legal record for you, they also provide subtleties we aren't always taking into consideration on first glance. Lip mobility is important to identify to be successful when you need to hide that transition line. You usually want to kind of keep that transition line about 2 millimeters above the lip line. You got to take a resting photo and then as well as a smile photo, but you also want to take the exaggerated photo of them smiling. There's a great variation between their natural smile and an exaggerated smile, and you really want to get that exaggerated smile in order to identify how much bone you need to take away. Profiles images also allow you to evaluate the asymmetry as well as the lip support. Here's a great example of why photos really matter. A quick assessment, you might think, or she has a low lip line, less default to the standard 15 millimeters of reduction. This is a home run case. But remember, hiding the transition line is key. Look at the zenith of the left and right canine. You can see that there's a difference. This patient has a cant, and taking this into consideration is key for success. Now the cant does 2 things. It doesn't mean you have to reduce more bone than you were planning in order to get that transition line above this zenith, but also means your AP spread could be greatly reduced as the sinus kids kind of creep on in. It's something to kind of think about. Now, this is another great example of why an exaggerated smile is key. You can see on just normal smile, it doesn't look too bad. Then you have a case like this where you have exaggerated smile where 50 millimeters is just not going to cut it, more like 20. Now, surgical planning. Most practitioners' goal is to load within 24 hours, but normally right after surgery. As I mentioned, the minimum torque is about 30 Newton centimeter per implant. And the reason for this is most multi-unit abutments need to be torqued in around 15 Newton centimeters. And if the implant is not really gaining at least 30 Newtons, it will spin when you place the multi-unit. If you do not, but there's a caveat: if you don't load immediately, a conventional denture, is usually made as a backup, and these usually don't go too well. You've already reduced so much bone, and there's a lot of extra tissue and swelling. They're going to be in your chair getting relined quite often. Now, the caveat is you don't want to have too much torque. If you have too much torque, you're going to cause localized pressure necrosis, and the implant will likely fail. The good news is that most planning software and guides will tell you where the bone is the best to gain stability and also help you kind of plan out the best AP spread and the restorative placement, but also kind of give you an idea of what kind of bone to expect. Now, I want to run through this quickly, but the maxilla tends to be the trickier jaw, and the concept of facial buttresses does play a key role. Um, Now, the buttresses are areas that basically take the load of mastication. These areas were also, the best placement for implants tend to be, as well as when I'm doing plates and screws on fractures. These are where I also want to plate my plates and screws. As you can see, you know, um, there's vertical and there's horizontal buttresses. When you place your axial implants, you usually are trying to engage into the hard palate region. But also, you can see, extra alveolar implants like zygomas and pterygoids also take advantage of these areas. So they tend to be the stronger bone. Now, how does all come into play? Well, this is your typical all-on-4 pattern, also called all-on-4 in a shelf. Um, Ideally, you want the implants planned for the lateral incisor as well as the posterior implants placed or where the head of the implant comes out around the second premolar. Usually tilting around 30 to 45 degrees. So the axial implants usually engage into that. You want to kind of sneak into the hard palate region, also the nasal floor, as well. While the posterior implants tend to be in the piriform rim region. Um, Again, kind of getting into those buttresses that we spoke about. And the key is you really want to try and get that primary stability. Now, sometimes it's not always the case. When the bone and signs are not ideal, there are some other patterns described. There's the M4 pattern described by Dr. Jensen, where the implants are placed, in a shape of the letter M. Um, in an M4 shaped configuration, the implants are actually angled. The anterior implants are actually angled distally around 30 degrees, and they're planned to also engage into that lateral nasal rim region. That's where you're going to find some good dense bone. There's also is the D4 pattern. We have a really severe resorption, not really for the novice user. And we have severe resorption. Commonly, you're going to have the sinuses creep in, and the AP spread tends to be reduced, and you might have to do what's called a transsinus implant, where you basically lift up the medial portion of the sinus to try and engage that lateral nasal rim as well by going through the sinus wall, while you're exiting the head of the implant through the premolar region. Again, for those who are just starting, ideally the all-on-4 on the shelf case is really where you want to start. That being said, is there any benefit of any of these patterns? Maybe a little less stress on the bone by using the longer implants that can dissipate it a little better, but nothing to call home about. They all work. You basically need to find or fit the implants to the bone that you have. Don't worry about the pattern as long as you get primary stability. It's all going to end up okay. So what are some keys to primary stability? Well, the basics are using longer implants, engaging into dense bone areas that we discussed, undersizing the preparation or the osteotomy, aiming towards a lingual paddle shelf to kind of engage in that thicker bone. And one other trick is on your final drill, slow down a little bit to reduce the chatter and the heat. One major factor as well to gain primary stability is the implant design. I'll tell you, there are many implants out there that have modified their design, like Nobel and also Astor, and I've used them all for All X, but I've made the change to the Biotech Contact implant in my clinic to do my All X's. The Contact S Plus I would use for areas where there's been extraction and non-extraction areas. I would use the Contact. I found that these implants just bite unbelievably well. I always find to be torquing out, which is my goal for my All on X. Now, I'm no fool. These are not, I don't want my patients to be guinea pigs. These implants have been produced or Biotech has been in business for over 30 years. They're not just figuring this out. They're just new to the U.S. market. They've gone through trial phases for decades. It's a high quality product. What I like about this implant system is I can switch between the two implants using the same surgical kit, saving time and space in my office, as well as I'm ordering the same drills for the same kit. I found the design of these implants maintain bone very, very well. But what I really, really like about these implants, not only do they work really well for the All-on-X and get great grip, but they're cost effective. All the parts for these implants, fit in the same interface. I don't have 50 different implant, types of multi-units, because no matter what system you use, it'll all end up in the same standard platform used by the majority of systems out there. They all come back to the universal 1.4 millimeter screw in the multi-unit. So it doesn't matter what implant size I place, it all just fits. So, and this goes for the S and sorry for the contact and the contact S plus. All the parts are compatible. And one thing is, if you're going to be doing all on fours, you need a lot of parts, a lot of pieces stocked up. So this takes a lot of inventory, also cost in your practice. I found the cost of implants to be about half of what I was using for my competitors. And another reason for me is that these prosthetics just fit incredibly well. For those who have ever seen placement of a multi-unit, half the struggle is ensuring that the button is actually engaged, all while you're holding it in place, trying to screw in the actual multi-unit to the implant. These implants just fit really well with their STS indexing system. Things just lock in, but also because how well the Morse taper fits, it really prevents micro movement transmitted to the prosthetic screw, which are like tiny microscopic screws, just adding to the overall strength of the prosthetic. So you really need a good screw, and also having these little extra features make the surgery just more smooth. Let's kind of go over a maxillary surgery, a typical case. So now that being said, this case was a little challenging. All right. Obviously, I went through the planning. I took my pictures, but you can see on the X-ray, we can expect a maxillary cant, meaning we'll have to remove more bone on that right-hand side. There's large pneumatized sinuses into the second premolar space, affecting my AP spread. There's flaring of the anterior alveolus, which means I'll have to have a great angle correction in my implants. This is kind of how the planning went. It was based on her functional and aesthetic needs, and we took into account her functional limitations. She happened to be a tiny lady, didn't open very wide. The extra reduction required to align and straighten the bone and the creepy sinuses meant my distal implants would be limited in my AP spread. This is my design. My design with the lab. I opted to take the second premolar out because I really don't like having cantilevers if I can avoid it. Yes, it's not Instagram sexy. I'm not a fancy guy. It's functional without the cantilevers, and this gave her a great functional result, and also aesthetically. Now, one of the most important things to do when you start this procedure is your flap. You really can't be scared. I like to try and save all the keratinized tissue if I can. I like to make a crestal flap around them. I like to have solid buccal releases so I can really have a great reflection, so I can see everything also fit on my guide. Also gives me great room for my alveectomy. And again, there's not much anatomy that you can really harm here. No, especially when you're back in the molar region, there's no arteries or nerves popping up. Really safe, also makes your surgery just so much easier. Flapping the tissue is vital in importance, as all progressive stages are dependent on the fixation base being accurately positioned and secured to the bone. This is the stable point for the entire system. Now, this guide is from my trusted lab. I really wasn't ready to switch over to biotech just yet. I have a very good team that I work with, but I'm going to tell you, I recently switched over to the biotech stackable guides, as they are dramatically cheaper than my other lab. And also the head of the lab, Maris, is incredibly knowledgeable on surgery as well as prosthetics. And again, the bottom line, I'm saving about 600% on my guides now. The guide is fixated into place with bone screws. I prefer bone screws versus pins. They're just more stable, and you put a lot of pressure on these guys, and vibration. I just find that they work better in my hands. The teeth are removed atraumatically as I can. I usually use a bone burr or a reciprocating saw. I happen to be using a fissure burr or a bone burr in this image, and you can see the bone is flush to the guide. And now I have the amount of reduction that I need to hide the transition line. Of note, after the actual guide is out, I'll come back and reduce all the sharp or the pointy parts. It'll make for a better prosthetic, which be less uncomfortable, as well as aid in the cleaning of future prosthetic. I start with preparing the anterior implants first. They are the easiest, to be quite honest. Remember, this all kind of planned out ahead of time. I know where the best bone is. The posterior implants tend to be more difficult to access when you kind of add on the offset of the guide, the longer drills, and the Pac-Man effect of the mouth. Of the mouth when you start moving posteriorly, it makes it quite some work to get these drills in. Also note that when you make these guys, you really want to request a lot of space to allow for irrigation. Obviously, this is within limits of the structure of a guide. Now the implants are placed. One thing I do want to point out, another great feature of the system is that indexing is so much nicer. You have a huge landing spot. Those black markers are easy to see, easy to line up. This plays a great role when it comes to the placement of your multi-units. Again, loving the torque on these S Plus implants. As I mentioned, the posteriors can be difficult to kind of get to, especially with the guide offset and the longer drills, and you add on the length of the implants. I'll commonly place my posterior implants without the actual doing it freehand versus guided. Again, getting great torques on those posterior implants as well. The multi-units are now placed. They come in straight or 0 degrees, 7 degrees, and 30 degrees angle corrections. Normally, these are indexed. Remember, you have 6 positions to choose from. That's why timing is critical for the best placement of the screw access hole. Note that we do have a non-index option as well if you really need to get that degree of freedom of movement, especially after the implants are integrated. You might have had a oopsie moment, but this really shouldn't be an issue. If you're really off on timing during the surgery, you can just rotate the implant to get back into a better spot. They also come in different heights based on the tissue needs. You really want these to kind of stick out of the gums, so your prosthetic placement is much easier. Also, a little heads up: Vitek calls their MUAs conical abutments. I'll be calling them multi-units. Now, as you can see, the care comes in the prosthetic kit and allows you to place the MUA with ease, not only with that nice Morse taper in the STS system, but these kind of drop in nicely. You can also use the care to kind of give you an idea where the implant head is coming out. Again, this is all planned ahead of time. I know exactly what my MUAs will be, the size as well as the degree of angulation. It's all kind of in the notes from my lab. These are longer surgeries. When you're kind of at the end of it, you're a little bit tired, and all this planning just kind of pay off. The straight. What I also like about the Biotech system is that the straight, although the multi-unit straight or the angled anyways, they're all torqued around 20 newtons. So that's kind of nice. There's some systems that have a variation between the straight as well as the angled. Now, after the MUAs are all placed, I then normally start grafting around those implants. Grafts really should be placed around implants with gaps of 1 millimeter or more. If you see a thin buccal plate, you really should kind of graft around that as well for the long term or the longevity of the implant. Obviously grafting leads to thicker buccal bone. I prefer to mix PGRF mixed with allograft to make sticky bone. I find that it just kind of, it heals nicely, as well as the PGRF tends to cause less discomfort, at least what patients tell me when I see them for post-op. I usually cover all this with PGRF membranes to encourage keratinized tissue growth. And I suture things up after the healing caps are placed. So the healing caps are placed, the tissue is trimmed judiciously. I really want to conserve as much keratinized tissue as possible. I usually close up with 4-0 chromic gut. Some people use longer acting sutures. I find that the patient tends to complain they kind of feel food stuck under their prosthetic, but this tends to kind of be the actual suture. The goal is to kind of push all this tissue down to make the multi-unit platform visible when you're doing your conversion. Again, there's many ways to kind of do this. You can just do interosseous sutures where you put holes in the bone and kind of suture the tissue to the bone. There's a famous Texas two-step closure where you do a running vertical um, followed by a running baseball stitch, either or. But the key is you really want to kind of push this tissue down in order to make that multi-unit visible. Conversion, traditionally, we would kind of put on these temp cylinders, make these large holes and try and, make the temp cylinders poke out of the prosthetic. It tends to be slower, messier, and create a lot of, weak spots in the temporary prosthetic. Also adds lots of bulk overfill, meaning lots of time was meant smoothing it out, and also patient complaints of discomfort. There's also the newer smart conversion, which is kind of a step above the traditional. Basically, it's a pickup in pressure with several fasteners. It's quicker, it's cleaner, and the holes tend to be smaller, meaning a stronger prosthetic. Nowadays, we've converted to a digital design. This is all where things are all kind of moving, where a digital designer will design the denture based on the position of the implants. This is all done digitally. You print it in your office. The printed denture, the printed denture tends to be smoother, have less bulk, making the prosthetic much more comfortable and less chair time of you adjusting. But the best part is if anything ever breaks, if you do enough, these are going to break once in a while. You just print off a new one, saving lots of time. But also, of course, you have a stronger denture. I said it's quick. The holes are smaller. There's no temp cylinders, which saves you money, but also has less points of weakness. And again, the greatest advantage is if things break, print off a new one. Obviously, it adds extra cost. The cost of the printer is as well as the photogrammetry unit as well, which can be pricey. But again, this is an investment, and it's a great service. What is phototomography? I'm sure everyone's seen it all over the internet. It's that little camera that uses the dice-looking objects, which are attached to the multi units. Essentially, it is a fancy camera in a way. It's not new. It's been applied in dentistry since early 1990. Phototomography essentially is an implant position. It kind of transfers implant position system. It's only capable of recording the fixtures coordinates, not the actual scan of the actual arch. You actually still have to do an intraoral scan. But it reduces the need for conventional methods in full arch without the need of a verification dig on your final prosthetic. Things fit really, really well within an error of 10 micrometers. That being said, if you ever kind of torque down a zirconia fixed prosthetic, you don't get that kind of screeching sound when you start to kind of tighten things down, which kind of make it a little uncomfortable. Again, it's very simple to use. After surgery, this happens to be a picture of one after things have healed. But essentially, you take your intraoral scan. You're going to use your phototomography unit. It's basically going to create a 3D model, which basically gives you a verified position of the implants in relation to the jaw, and then you can essentially, again, day of surgery, have a designer have a temporary prosthetic ready for you shortly. It's very easy to use. The whole thing doesn't take more than about 20 seconds to 40 seconds to actually do. But again, it is a bit of an investment. Here it is in action. Very simple. It's my first time doing it. Took about 20 to 40 seconds. It was great. Now, I chose an older case, but here we're actually going to see a quick convert case. Here's the quick converts abutments. Again, also a quick procedure. Here's my local lab that I used to hire to come on in. Again, great savings because these guys are not cheap to come on in. Here's her temporary denture delivered the same day. Okay. And actually, here's her 4 months later. You can just see how well the tissue is healed, the response of the implants to the tissue. She's going to have a great outcome. Especially lower. All right. Mandible notes. The mandible tends to be the easier jaw to do. The bones are denser, thicker. The biggest challenge is usually either the mental foramen or in the posterior. You can have a lot of resorption. above the canal. The main thing is check out, when you do the mandible, make sure you look at the mental foramen. There is an interior loop of the mental foramen or the iliac nerve kind of looping around on average an extra 2 millimeters. So you really want to say those cone beams carefully. You need about a 2 millimeter safety zone on the distal aspect of your implant. But again, check out the cone beam carefully because these can go as long as 5 millimeters. That can definitely make your surgery challenging. Another challenge is that the bone tends to be much more dense, which is a good and bad thing. You want to make your osteotomies maybe not so under prep, and sometimes you may get so much torque that you want to use some kind of bone reamer, to actually try and size the actual implant to the osteotomy, but maybe consider do maybe 3/4 of the length, so you still maintain some primary stability. Obviously, I'm an oral surgeon, so I'm going to show you some cool fracture images. But some things that you have to know. You don't need to, do under sedation. A lot of these can be done under local anesthesia. It's kind of nicer when the patient can open up wide and they're compliant, especially for those posterior implants. Sometimes, on my temporaries, I actually will cut the temporary near the most distal access hole to produce less force, especially when I have those cantilevers. You don't need to immediate load. If you don't have zygomas or pterygoids in your armamentarium, that's fine. Let's let it heal. This problem didn't happen overnight. You can let them heal in their dentures, and they can come back and have it converted later. I usually allow 4 months to heal. They're on a non-chew diet for about 3 weeks and a soft diet for the remainder. When I say non-chew, I mean cheese, puddings, popsicles, jellos, ice creams, yogurts. Soft diet being like ground beef and pastas and fish, things like that, or even cooked vegetables. I make sure that that they get good hygiene instructions. They're still treating these like teeth. They got to brush their dentures twice a day. They have to rinse their mouth, after every meal, especially in the first, 3 weeks. After 3 weeks, they can start using, water pick or super floss. I usually give steroids, antibiotics, as well as Exparel. If those who know what it is, basically it's a long acting anesthetic that kind of keeps the discomfort away for the first 3 days. On the final check, I will actually remove the prosthetic. I'll torque all the implants to make sure there's no pain or spinning of the implants. Of course, I'll check the tissue, make sure that there's no areas that are looking kind of ugly or bleeding or friable. Take a final X-ray, of course. As a oral surgeon and working with my restorative doctors, I usually will take all the photos. I'll scan with the white caps or the abutments provided by ICAM or my photo tomography unit. I'll take the IOS, of the full mouth and in the bite, and actually will send it off to the lab of preference. Again, I usually have all the investment, so it's very easy for me to do. Now, the one thing, when you are, placing these multi-unit screws back with the prosthetic screws, you don't want to kind of go in a straight line. You want to go in a kind of star pattern to make sure that you aren't, causing the prosthetics to slowly untighten as you move forward. So you kind of want to go, 1, 2, 3, 4, 5, but again, not in a linear pattern. You want to kind of go in a star-shaped pattern when you're screwing down these abutments to make sure that they get super tight. Well, I hope you learned something from this lecture. I hope you can get I hope you got the why portion. It's not a new trend or a business model. This is treating people and giving them back their old, and kind of rehabbing them and giving them back their confidence and their life back. I hope you figured out my why. I said, remember that patient with the very, very got me smile again. Look what happens when you change their lives. Again, you see that they're smiling wider. They're happier, healthier looking patients, and these patients will go on living differently. I want to thank you for your time. And is there any questions? All right. Is it 10 degree per? Oh, sorry. All right. So the 10 degree per per wall or 10-degree internal taper in total. It's 10-degree internal taper total. In the case of the M pattern or V pattern of implant placement, yes. So when you place these implants in the V or the M pattern, even in, ideally we'd like to have some space, but they shouldn't be touching. But they can get very close together. Again, there's a very little, a small landing pad to where you can get these implants to kind of place. All-in-one removal or fixed. The all-on-4 is a fixed prosthetic. So the goal is that you want to have something that does not come in and out of the mouth. You actually want to give them teeth back, not a denture, but give them teeth. Another question is, what do you charge per arch? Usually my set fee is $17,500. That includes everything. So I call, sedation, the guides, the implants. That's what I charge. I see it varying all the way from 30,000 arch, but that includes the actual prosthetic. It also, people will charge if it's all-on-4 or an all-on-6. I rather always try to do an all-on-6, or at least have the most distal tooth supported to, because again, these are lifetime patients. I want to have the least risk for failure or fracture, because if something does happen, it becomes my problem. So again, I just try and always do a continuous beam pattern, because I want all the implants supported. It's not possible to use bone to do FP1. So FP1s are a little bit more difficult. It takes a lot more planning. To be honest, I don't do many FP1s. It takes a really good, I guess, restorative doctor. But again, if you have the ideal situation where you can do an FP1, that is great. So yeah, an option is if you don't have enough room, to reduce for the thickness of the prosthetic, and you have the ideal patient with the, the right bone height, the right gingiva, an FP1 is possible, but again, it has to be the right patient. Those are very difficult cases, and they take a lot of planning. How much time do you take to do a full surgery? Well, my surgery probably takes me about an hour and a half, 2 hours per arch. To be honest, I do the actual conversion myself, meaning that I should put all the parts and pieces. By the time they're sedated and I do all my work, I'm a little bit more nitpicky, but usually an hour and a half to 2 hours per arch. So my follow-ups are usually 2 weeks after surgery. I choose 2 weeks for the first follow-up, just because a lot of problems self heal or go away. I tell all patients, day 3 to 5 are your worst days. After day 5, things will slowly start getting better. In about 2 weeks, it'll be as though nothing has happened at all. So normally all those aches and pains, those small issues will kind of self-resolve. If it's past 2 weeks, that's when I start getting a little nervous and I want to actually look into things. My final check, to be honest, after that is about 4 months. After 4 months, I mentioned I take everything off. I torque all the implants. I check, the X-rays and make sure these implants have all integrated, and then I actually do all my workup for my restorative doctor to move forward. So next time they see my restorative doctor, they actually will have a framework to try in. I guess that's all for the questions. I want to thank you for your time. For those who want to email me, ask me questions afterwards, I'm always here to answer. It's readydds@gmail.com. Again, I thank you for your time tonight, and I hope you guys go on and change some lives. Thank you again.
Thanks for attending this Viva Learning webinar. In order to get your CE credit, you will need to pass the CE exam. To do so, return to the website, make sure you are logged in, click on either CE in Progress or My Account. Click on the webinar title and take the CE exam. Thank you, and see you next time on Viva Learning.